This is a Relativity series bonus episode from LA Theater Works and the Alfred P. Sloan Foundation, bridging science and the arts in the modern world. Since there's a lot to unpack in Donny's brain, our producing director Susan Loewenberg spoke with Dr. David Hovda, the director of the UCLA Brain Injury Research Center.
Dr. Hovda, welcome to LA Theater Works, and thanks for joining us.
Thank you. Happy to be here.
Donny, the protagonist of our story, wakes up in the hospital several weeks after a car accident. If you were to see a patient exhibiting Donny's symptoms, including prolonged memory loss, seizures, mood swings, what kind of treatment or therapy would you recommend, and how complete of a recovery would you expect a person to make after, let's say, 2 months of being in a coma and then waking up?
They would stay within the intensive care unit, and there would be a team of neurointensivists that would be monitoring the brain's activity. We'd be measuring them for seizures. We would be measuring them for responsiveness. Can you tell me your name? Can you tell me how old you are? Can you tell me where you were 6 months ago? You're not going to remember the accident. I introduced myself to you yesterday. Do you remember me? Those types of things. And then once we get to the point to where they're what we call stable, then they get taken out of the intensive care unit and put down into another unit in the hospital where they don't need as intensive monitoring, but they have pretty close monitoring with a nurse for a couple of weeks. And then they get discharged for rehabilitation. And rehabilitation is where the $100 million issue is.
What do you mean by $100 million issue?
We can save lives. We've saved lives a lot better now than we did 10 years ago. We can get people out of the intensive care unit alive a lot better than we did a long time ago. And that's due to great physicians and great neurosurgeons and great monitoring of the intensive care unit. But you know what patients want is, okay, I'm alive. When can I do what I did before? Why can't I see things the same way I saw them before? Why do I have these problems with emotions? Why do I all of a sudden have a short temper? Or vice versa, why am I so lazy and lethargic that I have no interest in my loved one or my children? Why are these things going on? And why are things confusing to me? Why do I get seasick all the time? Why do I have these headaches? And that is the challenge in rehabilitation for traumatic brain injury in patients. And unfortunately, many people begin to give up on both the patients and the patient's family awfully soon. The old data, the old way we used to think, was that once after 6 months passed, that was as far or as much as you were going to get back in terms of recovery function. Say he was in a coma for 2 months, he would have a reasonable chance of recovery depending on the damage that he had. Now, he also had seizures, and acute seizures do happen following traumatic brain injury, but usually seizures develop later in life, long-term after traumatic brain injury. The amnesia is a very common problem, even following mild traumatic brain injury. And that amnesia is actually a kind of a blessing, because for some reason Mother Nature takes away your memory of just before and just after the insult. And so all the horrible things that we end up doing to patients in the intensive care unit, they don't remember. And in fact, family members will go through great lengths to take notes and journals to make sure that they can explain to their loved one what happens. One has to remember that traumatic brain injury doesn't happen to one individual. It happens to the entire family or an entire unit. And so everybody wants them to know what they all went through. And some of this is helpful for the family that has not directly suffered from the traumatic brain injury, but who has to endure watching a loved one being in an intensive care unit.
You made a distinction between unconscious and coma. What is the difference?
So I can wake you up from unconsciousness. I can put a capsule of pneumonia underneath your nose, or I can slap you around a little bit and get you moving, and you can actually respond to pain and stuff like that. And there are different levels of coma where people can become so unresponsive that they will posture. And what I mean by posturing is that they will, if you've seen pictures of individuals which are in a vegetative state, they look like a fetal position, and that's called posturing. And there are different sorts of posturing which has to do with different types of injuries, different severities of injuries. Those people are not responsive. And then there's this in-between state, and we called it a minimally conscious state, where we think they can hear us, or we think they respond, but we're not absolutely sure. Families typically err on the side of, yes, I know they can hear me. And so they always want to talk to their loved ones.
And is that helpful?
Yes and no. Let me give you the yes first, okay? It's helpful for the family. We train residents to work with traumatic brain injured patients that are in a coma. We ask them to address the individual by name. Mr. Johnson, I'm going to turn you to your side. Or Mr. Johnson, I'm going to check your eyes. Or Mr. Johnson, I'm going to suction your mouth so that you can breathe a little easier. So you always get an understanding that this is an individual with rights, and this individual deserves the respect of a person, of a human being. And it's not just something that you're trying to get rid of because it's so far gone. The bad news about it is that the brain requires an enormous amount of energy to recover from traumatic brain injury. Normally, the normal human brain runs on about 116 watts of power per hour. That's kind of like a dim light bulb. But to recover from traumatic brain injury, the brain has to start activating certain types of pumps and enzymes and channels and proteins and genes that's trying to save itself. And that creates an enormous amount of energy.
Can you create more energy? In other words, can you create more wattage?
Yes, you can. As a matter of fact, if I measure your visual system and I have you close your eyes, your energy goes down. And then I have you open the eyes and stimulate it, then your energy goes up. And the way that you get your energy is primarily through a compound called glucose, which is essentially sugar. The brain doesn't store sugar, but the brain uses it in order to generate energy. And it uses it through a different set of pathways, some that involve the use of oxygen and some that don't. And what happens is that after traumatic brain injury, the brain wants to utilize as much energy as it can possibly generate in order to repair itself or to stop cells from dying. So if you have patients in an intensive care unit that are going through this problem of an energy crisis, and you stimulate the brain again with either like a seizure or an increase in what we call intracranial pressure, so the brain swells and it starts to injure itself.
But are you inducing that, or is that happening by itself?
So it can be two ways. The patient can induce it, or if a mother wants to put earphones on their sons and play Van Halen or whatever music they want to do. We have no scientific evidence to date that I know of that causes damage to the brain. But as a scientist, I become worried because that causes an energy demand that I don't want the brain to have to expose itself to when it's already trying to recover from this devastating head injury. So a lot of ICUs, a lot of neurointensive care units around the country have gone to the procedure of trying to put patients in bays. ICUs are divided up into bays, so equipment can be moved back and forth. So put them into bays that are relatively quiet. I don't know if your listeners or if you have been in an intensive care unit, but it can be a very loud place with alarms going off and people crying and people upset and angry. And so we try to get them in a place where it's relatively quiet. Now, does that help? Does it protect the brain? We're studying that. As a matter of fact, we know that the glucose that you use after traumatic brain injury may not be doing what we thought it did. And so we're thinking of trying to give it an alternative fuel so that we could give it like when an athlete gets spasms on an athletic field, they'll take Gatorade. Could you imagine a Gatorade for the brain? Maybe we're hanging the wrong thing on the IV bag.
In the play, we hear Al walking Donny through a series of memory exercises as part of his inpatient recovery. How accurate is this depiction, and what other exercises or activities are important in helping patients regain shorter or long-term memory, for example?
Well, there is a concept called confabulation, which is just putting parts of the memory together and then making a story out of it, whether it's true or not true. And it's a psychological term. And patients will often do that. So there's called retrograde and anterograde amnesia. And it's just the difference between before or after the trauma. So the distance in time is very short before the injury, where they have forgotten. The distance after the injury usually is longer. So walking through memory lane and trying to say, well, you wanted to be a football player, you wanted to date Susan, or they would probably remember that going up until about a week before the traumatic brain injury. And then things would be gone from that point until probably months after the injury, maybe even a year. Recapitulating all the things that happened during that time certainly does make the person say, well, that's what I was like. So I did do that. I did like Susan, or I did want to become a football player.
Now, are you saying that the therapist says, do you remember that you wanted to be a football player? Or you did want to be a football player, right? I mean, is that the kind of thing you're talking about?
Yeah, there are two ways of doing it. If you prompt them, then they say, you know, before your head injury, you wanted to be a football player, or you wanted to be a track star, or you wanted to be an actor, or you wanted to be a doctor, or something like that. Then the patient may realize that now they don't. Now they've understand what they've lost. And so now the idea is to try to bring back these memories so that you remember what you were like. And I think from a professional point of view, my position would be that that's okay for everybody to try to do that. But for the individual, for Danny, it's much more important to realize what he can look forward to in the future, or what he can dream about, what he wants to be, as opposed to what he was going to be, because the traumatic brain injury may have taken that away or may have altered it significantly.
So basically what you're talking about is giving people hope.
The worst thing you can do to a patient is take away their hope. Mm-hmm. The best thing you can do for them is tell them, you are different. You're not hopelessly different. You're just different.
Or you're not less.
Or you're not less of a person, or less important, or less appreciated. Unfortunately, sometimes families have a difficult time with it. So there may be situations where people can't tolerate an individual like that.
Donny frequently seems confused about the linear sequence of events, or to conflate events from different periods of time. How common is this in patients with brain trauma from accidents of this kind, and what are some of the other typical symptoms they may exhibit?
It's very common that people would get things out of sequence in terms of the timeline, because in our everyday lives, time has a certain perspective. We know when it's morning, we know when it's night, we know when our mom's birthday was, we remember when our father passed away. Some of us remember where we were when John F. Kennedy was shot, okay? And we would be able to put a timeline on it. And following traumatic brain injury, many times people will be able to say, I remember that, but I don't remember when. And it could be mixed up for a period of time. Now, that may clear over the course of, say, months to years. And one of the beautiful things about Mother Nature is that we forget. And we tend to forget the bad things. And we try to, for some reason, we remember more of the good things. And as Danny becomes more engaged in his new self, his new normal, if you would put it, then all of a sudden the time frame becomes more normal and it would become easier for him to do it. But with severe traumatic brain injury, a lot of therapists in rehab will have individuals keep a journal or a document that they refer to. Okay, today is Tuesday, so today you take the trash out. And before you had an injury, you didn't need that. You just remembered it. So you need an aid now. Does that make you any less of an individual or less of a person? Well, it does make you dependent on something else, but you may be able to get around it. I use the example of stroke. So if you had a stroke on one side of your brain, you may not be able to use, say, your right hand, and you always brushed your teeth with your right hand. So somebody taught you how to brush your teeth with your left hand. Now, there are some people here in the United States would say that that's recovery. That's recovery of function. In my profession, the way that we look at it, that's not recovery. That's called masking the deficit. So we've just used a different technique in order to get the same response. And the brain can do that. You know, if we didn't have the capacity to recover from traumatic brain injury, teleologically, we would have been somebody's breakfast. We would have never evolved the capability to do this.
I was going to ask you, are there ever any instances where somebody has a really severe brain injury and they actually recover completely?
Oh, yes. Yes, of course. I can think of a number of times. Now, by what you mean recover completely, nobody really knows what that would be. Usually because this happens in younger people, you don't know what their capacity was going to be at the end. You don't know if they were going to be an attorney, or they were going to be a lawyer, or they were going to be a sound person for a movie, or they were going to be a producer, or they were going to be an interviewer. There are all kinds of different skills that people have. So we can't predict what they could have been. But in terms of, say, going back to college, getting a degree, getting a master's degree, being a successful business person, or contributing to society, or falling in love and raising a family, and raising a, quote, normal family, if there is such a thing as a normal family anymore, that does happen. Does it happen often? No. Not following severe traumatic brain injury, but it does happen.
In the play, Al conscripts Emma to help Donny recall the facts of his life. How common is it for doctors to enlist family members for this purpose? And what are the ethical considerations in asking family members to take on this responsibility?
So I would probably say the answer to the first question is rare. There are certain things that a physician's responsibility is towards the well-being of the patient and will advise the family accordingly. Usually our hospitals are so busy, there's another patient that has to be taken care of. This has usually been a family decision, whether they were going to do this or not. And there's one thing I've never heard in the intensive care unit. I've never heard a family member tell me, only do what's physically responsible to help my loved one. And they'll often ask, would it help if I talk to them, or if I stroke them, or if I hold them, or if I tell them stories about what they were like and recapitulate their life and what they meant to us all? I always repeat this. I said, this brain injury didn't happen just to Danny. It's happened to all of you. So if it helps you all to help him recapitulate this, This is fine. Is it going to change Danny's outcome? I don't know. I hope so. My advice has always been, whatever you want to do, as long as it's not physically hurting this patient and it's not economically hurting you as a family or this patient, then fine. And I have been surprised at the number of times I've seen families come in and they have group prayers and just pray for this individual, and they're convinced that this is changing the brain and affecting the recovery of function.
In the play, Al describes the idea of plasticity, that the brain reshapes and recovers itself to compensate for changes over time, including trauma and damage. What are the factors that account for the plasticity of any given person's brain, and how does that change throughout a person's life?
Neuroplasticity has been studied for over 100 years. We used to think that once a connection is broken and it's gone forever, there was no sprouting or reorganization of the brain. And in the 1960s, it was discovered in a rodent model that, in fact, this does happen.
So what you're saying, a connection gets broken, and then it somehow figures out a way to reroute itself?
Yeah, there are several different types of reorganization in terms of the axons, which are the connections between one cell to another. One is called regeneration, whereas the axon's been severed and it just regrows forward. What is more common is that there's a intact axon nearby and it sprouts and it takes over the function of the original axon. That's called axonal plasticity.
And does that happen by itself, or is that happen as a result of some medical intervention?
Happens by itself. We think we have a couple of ideas on how we can enhance that. One are called trophic factors. So if an individual is more active and has a good diet, the brain can manufacture more trophic factors and become more plastic. A good example of neuroplasticity is if we took our 7 or 8-year-old child and dropped them off into Paris and picked them up 2 months later, they're speaking French. If you drop me off in Paris, in 2 months, I'm still trying to figure out how to order a glass of wine.
Right, yeah.
And that's because the human brain, very young in life, is very, very plastic and can reorganize very, very quickly at a level where the axons change, but also at the synapse, where the synapse actually changes. And these synapses change in milliseconds, so you can always learn new things. And a good example is the recognition of faces. So I may have dimensions of my nose and ears and mouth, but you will recognize me immediately if you saw me on the street, because we've met each other. And you'd learn that, and your synapses have changed because of that. It's not because of some miracle medical intervention that has caused that to happen. Does the rehabilitation therapy who is trying to get you to move your hand a certain way or move your legs a certain way, does it help in that process? We think so. But we have definitive outcomes that we can help people to walk better, help them think better, help them learn how to conduct their daily lives a little bit better.
At one point in the play, Emma describes Donny as being, quote, a version of himself, one of the Donnys. How does the work in your field contribute to our understanding of how consciousness and identity are shaped and impacted by trauma?
Consciousness, we've learned, is not the same sort of thing that we would think of when we go to bed at night and sleep. But we do know that after traumatic brain injury, the brain is flooded with a change in neurochemistry. One of those changes is an ion called potassium, and it floods the brain. And it causes what a scientist by the name of Liao discovered in the 1940s, called spreading depression, and it shuts the brain down. And in traumatic brain injury, there's a lot of us that think that this is one of Mother Nature's way of trying to make the brain quiescent so that it isn't challenged during this time. Can I wake that patient up, or can I change them? You know, if I put you in an ICU bed and you have no brain injury and you're perfectly normal, and I make you stay in that ICU bed for 3 days, for every day you stay in that bed, it's going to take 3 days to recover because you're different. The experience of going through this changes you dramatically. Now, are there dual personalities? Yes. There's a psychological problem in people that have dual personalities. Can that be induced by a traumatic brain injury? Yes, of course. Brain injury itself can produce what we call post-traumatic psychosis, or problems in terms of thinking, or what used to set you off before in terms of your love or hate of something now doesn't bother you as it did before. And you may have good days and bad days. And on those good days, you may be the old Danny or closer to the old Danny. And on other days, you may have exerted yourself and now you're tired and now you're closer to what the new reality of Danny is. So potassium is a normal ion that helps us communicate within our brain so that we can actually speak, walk, love, feel, all the things that the human brain does. And potassium is part of that. And it's part of what is called the Nernst equation. And all that is that when the cells are overstimulated, so we're talking about cells that have survived this traumatic brain injury, in Danny's case, not the ones that are dead, that are on the pavement someplace. Those are gone. We can't recover those. But that potassium still has to be there. And it's just a flood of it. Now, if we wait long enough and we give it enough energy, the human brain has what's called the sodium-potassium pump. And it will re-equilibrate itself. But it takes time to do that. And we now know in mild traumatic brain injury, it can take up to 14 days to re-equilibrate itself, but it will. In severe traumatic brain injury, we're not sure. Because now we have a combination of injuries. We have not only this neurochemical problem, which doesn't require cell death, but we may have cell death and disconnection. And there are 3 things inside of your skull. There's blood, there's what's called cerebrospinal fluid, and there's brain tissue. And we know that inflammation, or swelling, is an important factor that we have to deal with following traumatic brain injury. And in fact, when Gabby Giffords was shot, one of the first things they did was they took part of the skull off. And that was because the brain was swelling, allowing the brain to swell so it didn't kill her. Because we only have, it's a closed box except for one hole. This inflammation then starts to retreat, and then we can put the skull cap back on. And that can be months after the brain injury. That process, if we took away the potassium, it would be really devastating for the patient. And I don't know of a way to do it except chemically suppressing it. And I think there's a lot of us now that believe that Mother Nature has got these mechanisms of recovery, and we just have to figure out how to help her in this process, as opposed to trying to make this person normal. Let's try to help Mother Nature with this process of recovery.
What kinds of developments are you and your colleagues working on that could potentially help brain trauma victims achieve even greater recovery than in the past? And what areas of research are the most exciting, in your opinion?
The most exciting research for me is research that I currently don't do, although I do a little bit of it, is the long-term recovery aspects of it, of trying to make somebody that's had a head injury 5 years ago even better 5 years down the line. And what can I do for that? I gave a lecture in a medical school class in the 70s. And I told the class of this wonderful paper that came out in Science, it's a magazine, that the brain makes cells, makes new cells, even in adults. It's called neurogenesis. And the dean of the medical school was very upset at me for lying to the medical students. Well, now we know that neurogenesis is a very common phenomena. It would be a wonderful thing if we could actually produce these cells in a way that helps recovery of function. They are unfortunately more susceptible to dying, and unfortunately they may be more susceptible to being glial cells rather than neurons. But for people that are suffering from multiple sclerosis, that may be fine to have more myelin in the brain as opposed to with glial cells, as opposed to traumatic brain injury. The things that we are currently doing today that I get the most excited about is that if we make this a very impersonal question about recovery of function for an individual, the better product that I can give to a rehabilitative facility, the better the outcome. Not so much how many cells do I save, but how much can I make sure the connections stay connected. There's a process that occurs over the course of days after brain injury, not minutes like we thought, but days, where we can intervene and stop some of the damage that can be done. So we may be able to produce a better product. Hence, that's why more people are surviving traumatic brain injury than they have before. So a better product may have more connections with which the rehabilitative scientists may be able to alter. The most exciting thing we have found in our particular research is twofold. One is that people don't study women very much, and they're not very good at studying children very much. And these are two areas that we are very interested in because we think that they respond differently following traumatic brain injury. And to treat a 7-year-old child the same way you treat an 18-year-old boy is probably the wrong thing. And women, before they're menopausal, postmenopausal, they may have a different response depending on the time of their sequence. Maybe the first 6 weeks or first 7 weeks may not be as bad or maybe worse than the last 2 or 3 weeks of when this happened. Can you get that data? Is that important data to get at? Hormones. The pituitary gland. Nobody ever looks at the pituitary gland. A lot of these emotional problems and sleep disturbances come from hormonal dysfunction. That's treatable. I mean, if you run a plate and you look for differences or problems in hormones, how can I measure vulnerability following a mild traumatic brain injury so I can help these young people get back on the field of play or get back to what they wanted to do in a way that's safe and in a way that is conducive to all the good things that sport has to offer. So those are the things that I'm the most excited about. What I'm the most afraid of is I don't know how many people out there in the United States or in the world that have suffered from a traumatic brain injury, that are having these long-term problems that are being misdiagnosed. One of the worst things to do is to give the right drug for the wrong disease. And if you misdiagnose them, you're just making the problem worse for these people, not better.
This has been absolutely fascinating. Thank you so much, Dr. David Hovda.
I enjoyed it. Thank you.
I've been speaking with Dr. David Hovda, the director of the UCLA Brain Injury Research Center.
This has been a Relativity Series bonus episode from LA Theater Works and the Alfred P. Sloan Foundation, bridging science and the arts in the modern world.